defibrillation in the next decade, well, I could theorize probably as much as anyone else on what's going to happen in the next decades. What I will do, I will, based on what we have currently available, technology we have currently available that is out there, either in an experimental way or sometimes even more already in clinical practice. I will show you what the value is, particularly with the aspect of defibrillation. First of all, Chromium CT guidance. Chromium CT guidance has been around for a long period of time. My experience is well over 15 years with this specific technique. It's a very simple technique. We can use it in the intervention room, and what we do is we simply use the flat panel detector, rotate around the patient, have a very nice reconstruction, and in this volume we then plan our ablation. The system then knows how to enter. It actually follows along your needle path planning by using the anti-point view for targeting and for actually using progress view for finding the exact depth and monitoring your needle with fluoroscopy as you go into the liver. What's the benefit of it? It does require less need for conventional CT scanning. You're working in a dedicated interventional oncology environment. It allows for live needle guidance because we have fluoroscopy available as well. And as I will show you in the next few slides, there's also the advanced option of planning and navigation software on the side. So in my opinion, this technology is actually a unique hybrid solution between CT and fluoroscopy. Looking in literature, you can see that the results of the only one randomized controlled trial comparing Chromium CT and CT guidance show that it definitely is of benefit, because percutaneous procedures with extraguide, they will improve your targeting accuracy, they will require less needle positionings, they will actually result in a lower dose for yourself and the patient at an equivalent diagnostic accuracy. A study that's not liver, it's actually lung, but to show you the effect of using Chromium CT in targeting a lesion. This is actually a study that describes the situation in lung ablation. And what is shown in this study, sorry about this, is that Chromium CT is definitely faster than CT to target and place an electrode independent from the size of the tumor. So, summarizing even before we started, but why should we use Chromium CT? In my opinion, it's the ideal tool to use 3D visualization. It has low procedure time. On average, placing the needles is usually a very simple procedure. A biopsy takes less than 15 minutes, and ablation usually less than 90 minutes. You have to be able to work in a dedicated working environment, especially when you come to the unfortunate situation of complication that you have to manage. It does allow for additional IR information and fusion imaging. I will show you some images later on. And also it allows for a hybrid solution where, for instance, you might want to go first for delineating the tumor by using a catheter-based approach and then go to CBCT guidance instead. And it has proven accuracy with the reduction of radiation, contrast and complications. So, we know there are limitations to Chromium CT imaging. Chromium CT is a technology that has a little bit slow rotation around the patient, so there might be some issues that we have to tackle as well. One of the main things is the fact that Chromium CT actually has a somewhat lower Hounsfield resolution. So in these particular cases, and in tumors that are invisible in plain straightforward CT scanning, it might definitely be helpful to use a CBCT overlay or fusion imaging, which can be done by either using the pre-intervention contrast enhanced images, MR images, or maybe even the use of PET images instead. The other nice tool we have available when we perform CBCT image guidance and needle guidance is the fact that we can actually use tumor segmentation. This is a tool that is made by Philips, which very nicely allows you to outline the different tumors in the liver, and then use this for your ablation planning, predicting the amount of ablation zone that actually is surrounding the needle. So you also get information on the effect of a certain type of needle. And this works in cryoablation, but works just as well in radiofrequency ablation and microwave ablation as well. The tools are all easily controllable table size. As you can see in this small movie, this is where I perform fusion imaging. I simply match the two volumes, which has to be done because we first have a supine patient, and then we are treating in a prone position, so we need to make the adjustment for the different orientation of the organs. In this particular case, I'm focusing on fusion with regard to the kidney. And going to the next one, where we not only segment the tumor. I apologize again, it's a kidney example, it's the only one I had on movie, but it very nicely depicts the way we actually plan our needles, the way we are getting the information on the different ablation zone, and then in the end we have a nice overview of how the ablation zone is completely encompassing our segmented tumor. It's also an important part that we can, from this technique, from chromium CT imaging, because not only does it allow us to have the planning information, but also what we can do is after we perform the ablation, we can fuse the two of them together and actually make sure that we have a nice overview and thereby confirming that we have ablated completely. And this is also a tip for the next 10 years. I strongly believe that in the next decade, we as intervention radiologists should really focus on ablation confirmation. Ablation confirmation as we perform the procedure and still being able to do some changes and maybe re-ablate a small area that we did not ablate at first is going to be mandatory. So a few tips on what we should do when we perform CBCT imaging. It's essential that the patient is all during the procedure in the same position. And for this particular aspect, I use a dedicated mattress. Mattress is actually a vacuum mattress, which allows me to position the patient in pretty much any position that is necessary. There's also a cushion that is very helpful for the anesthesiologist because it supports the patient in all different body anatomies. Another option of CBCT imaging, a very new option, is the fact that you now also have the ability to perform open trajectory imaging. As we know, it's sometimes difficult with rotational arc to encompass the complete volume of liver tissue within the rotational arc. In this particular aspect, we can use open trajectory imaging. Because of this, because of shifting the patient within the rotational arc, we actually can get a better centering of the liver contour and get an improved coverage of the entire liver volume. A second new technical option that is out there is the fact that we now no longer are restricted to certain flexible CR positioning because of having the option available for performing flexibly. Because what it does in this particular image, this is the old situation, you see that we can pretty much only move in the length of the table. In the new situation, we come from a parking position that's actually alongside the patient, and then we move it in. So it doesn't interfere with the position and the working position of the anesthesiologist, and it's at the same speed that we can perform now our rotational scans as well. A few words on chromium CT imaging and angio in TACE and liver ablations. One of the great benefits of performing chromium CT is that not only can we perform it in one direction, but we can also make use of the return direction for performing both arterial and parenchymal phase imaging in the same session. We have shown in literature that it actually helps in increased detection of different liver malignancies, but also can show you a little bit on the perfusion dynamics as well. If you look at the images on the right, you see that it actually also is very helpful in improved detectability of liver metastases. Also, these different steps, for instance, in TACE treatment, is using this dual phase chromium CT is helpful in performing the technique of automated vessel detection. And this definitely helps us, it's called EMBOGuard, to navigate from a certain point in the relevant vascular anatomy to whatever area we would like to target for performing TACE procedures. This tumor-feeding branches detection actually shows very high increased sensitivity, and it's also that with the automated detection, you see that there's definitely a difference and an improvement compared to manual detection, as was shown in this study by Myanmar. It's not just that it's in one single case, but you can repeat this process over and over again, because also in different cases it will show increased reproducibility, as is shown in this inter-observer sensitivity. A new tool that we've been using when performing liver ablations is that these days we now first do catheter placement in the hepatic artery, and then by using the hepatic artery infusion of contrast, we get a very nice depiction of the tumor while we perform the CBCT volume acquisition. So this technique not only allows us for the tumor visualization, but it's also very helpful when we want to navigate our needles, and also afterwards when we want to confirm our ablation zone. And the great benefit is the fact that since we are performing CBCT imaging, we do it in the same room, and we don't have to move first from the angio room to the CT to perform a procedure and then move back again to remove the catheter. The initial results actually were published by a very good friend of mine from the Utrecht University, and it shows that over 90% of the tumors is visible with 100% technical success and no recurrences of primary or secondary. At the mean overall procedure time, it's just about the same as without all these new tools. The final part of my talk, I will focus a little bit on some new tools that are out there, some new things that we've been experimenting with. First of all, it's the technique of using robotic assistant technology. There's a great reason for performing robotic assistance as it helps in improving your accuracy, it reduces the dose, it speeds definitely up your procedure, it reduces human error, and also has a number of expanding indications. We have been using it for over 10 years now. The technology is very simple. The technique I use is a very slim profile robotic device that when used in CBCT guidance only consists of a control unit and an effector unit. That's all there is to it. And the effector unit is so strong enough that it even can hold very firm needles or needles that have a handle attached to it with some weight. These are some early results from an analysis we performed most recently. It's about setup time, about radiation reduction, and about the amount of time involved in robot handling. And as you can see, these are all very good values. So one additional remark to make for this is the fact that when you position your needle right in a multi-needle approach, it definitely helps you to speed up the procedure because it provides you with a proper fix on the target. Augmented reality is a new kid on the block. You will see some examples out there. Initially it was proposed very fancy in some images that actually show what we would like to go to, but this what I'm now showing you is actually real world evidence, and hopefully this movie will run. We had some issues during the setup, but it didn't copy, which is unfortunate because it very nicely shows you what is the effect of the technique. And as I will try 2 days into lunch exposure with Philips to potentially show you what the movies look like. This is another example. Why is it so helpful? It's helpful for us because we can now actually position our screens wherever we would like. So they're immediately in front of us, and when we work in different settings where we are actually using multiple screens, we are no longer restricted by the position of the physical monitors in the room. This is what it looks like. It also allows you for the use of additional tools like ultrasound and ablation equipment as well. Also, in my opinion, this augmented reality could definitely be helpful when we want, for instance, to minimize radiation exposure. It's an excellent tool to show you what's normally not visible. So you could actually depict what's happening in the room. You could actually look at the live radiation that's being administered to the patient, but also has a result for you. And in fact, you will actually be able to show what the radiation looks like even when looking at the patient. The next step in the next decade, what I think we should focus on is not only that we should use methylpyridol, but also we should consider the use of fiducious liver treatment, as has been the case in many years of stereotactic radiotherapy. They have already shown that they can get a significantly greater mean positional error is present when you only use liver comparison compared to fiducial-based setup. And there's also a higher inter-observer variability when you only align to liver instead of using fiducial markers instead. So my final remarks in the last 40 seconds of my talk. What I've been hoping to show you a little bit is what liver ablation in the next decade is going to be like, in my opinion. I'm a strong believer and promoter of using CBCT with fusion imaging for this purpose, because it allows you to not only do tumor segmentation and proper ablation planning, but also monitor what's happening and make sure that you're actually do your treatments, your ablations adequately. It does have its benefits in taste and identifying the tumor-feeding arteries. The special technique of hepatic arterioangiography and CBCT ablation has recently been published. I've hopefully been able to show you what the additional benefit is of robotic assistance. I'm sorry that the augmented reality video didn't work, but all of these techniques will definitely lead to dose reduction. And potentially I see there will be a role for the use of solutions as well. Thank you for your attention.